Welcome everybody. Welcome to today's webinar. Apologies for the slightly delayed start. We've had a couple of gremlins in Teams today, but hopefully things will run okay. So welcome to this webinar. My name's Russell Cartwright, and for those of you who are new to the Public Health Comms Hub, and I think there are quite a few of you on this call who are new, which is brilliant. Here's a quick intro to the hub itself. I set the hub up last year with the support of Can Digital as a place where people like us, so those of us working in public health communications, can come together and share best practice, solve problems together, and really try and sort of learn from each other. We've run several of these webinars now. Recordings of them all are available on the hub, and we are recording today's session, so that will be sent to you after the session, along with the materials. So you will get that. If you've got any suggestions for any topics that you think we should cover in a future one of these sessions, please do put them in chat, and we'll cover them if we can. And also, if you've got any questions for any of our speakers today, do please put them in the chat, and we've allowed a little bit of time at the end to take some of those questions. And any we don't get to, we will follow up and answer if there are lots of them, because it does look like there's quite a few people joined actually today, which is brilliant. So just to introduce myself, I've worked in the NHS in South East London for more than 23 years now. I'm currently working part-time as Assistant Director of Communications and Engagement for NHS South East London ICB. In the past few years, I've become a bit of an expert in running behavioural science public health campaigns. The campaigns that I've run have won several awards, and I've really kind of developed my knowledge and my passion for this area. So much so that now I split my time between working in South East London and also working as a consultant, training and supporting other in-house teams to kind of embrace this. I'm also passionate about helping people in our profession stop doing the things that we know don't really have much impact, or that we suspect don't really have much impact, and focusing on the things that we do. And that's why today's topic, I think, really aligns very well with that. And I'm really pleased today to be joined by Dr. Nupur Yogarajah. Nupur is a brilliant fit for this webinar. She combines her expertise as a behavioural scientist, clinical experience, and applying the science in kind of real life situations. So Nupur, would you like to introduce yourself, please?
Thanks very much, Russell, and thanks for having me here today. It's a real pleasure. I think you gave me quite a glowing introduction there. So as Russell said, I'm a sort of combined GP and behavioural scientist. I wear both those hats. I did a master's in behaviour change, which I finished 2 or 3 years ago, and very much focused my research on health inequity. So for me, it was really insightful about how we can start to apply a really sort of evidence-based process, even when we're engaging with communities and around research and improving things like health equity. I get pulled into, which I love, a lot of behaviour change and behavioural sciences, and seeing where my input can help around the system. I predominantly work in a leadership role for health inequity and population health for the ICB, focused in Greenwich, and sort of gave you my other hair, but also do some work outside of that as well, independently, around behaviour change focused things, for example, with community interest companies. So that's myself, really. Thanks, Russell.
Thanks, Nupur. John Paul, would you like to introduce yourself, please?
Hello, thank you, Russell. I'm John Paul from CAN, the Council Advertising Network. We help lots of public sector organisations run campaigns that target the right behavioural interventions at the right people. So when you've worked with someone like Russell, with someone like Nupur, and you have your insights and your messaging, we're the people that get it to the right people as and when they need it. Yeah, that's about it for me.
That's great. Thanks, John Paul. I'm just going to put a couple of slides up actually, but the first slide, which you'll see, has all of our contact details on there. And I think it's important to stress really that webinars like these are only possible through the support I've had from Can Digital and JP in particular. So yeah, I'm really grateful for that. So I mentioned that I'm keen that we as a profession are given a license to focus our efforts on areas where we know we can have most impact. And I'd like you all to take a quick poll now, please. So John Paul, if you could put the first poll up there. If people
really
just
sorry,
answer
Russell.
this. Oh, yeah.
The poll isn't working in Teams today, so we have that wonderful additional challenge. But if we could do it in the chat, do a quick sort of sample of.
Yeah. Okay. Sure. So the question we're going to ask you on the poll, and I wonder if it's because we've had so many people turn up today, actually, that could be related. There is a lot of people in the webinar. So the question we were going to ask was, or we'd like to ask, and if you can put a number in chat for us, that would be great. If you can think back to the last 5 projects that you've worked on, how many of them, so if you can give a number between 0 and 5, how many of these projects have you been satisfied with the impact and the outcomes that you've achieved with those projects? So please do put them in chat. Okay, so nobody's put 5 yet, which is interesting. There's quite a few zeros, and thank you for being so candid and honest, everybody. You know, it's exactly what we wanted, and this is a safe space here. I think the highest we've got is 3, which I think is pretty good, actually. You know, but yeah, I think it does illustrate that as a profession, I think we need to be able to do more of this. Now, if I was to look at lots of the different campaigns that I've been involved with, the behavioural science-led ones, I would be scoring most of those. You know, I would, yeah. If I classed 5 of those projects, I would probably have a score of 5. And that I think is where you really can have the impact. So there's clearly, you know, something we can do to try and increase our satisfaction in terms of what we're achieving. So I'm just going to move the slide on. So why behavioural science, or why behaviour change? I mean, very simply put, behavioural insights help unlock how people make decisions. They provide us with a deeper understanding of the motivations, so that's conscious and subconscious motivations that drive decision making, that really make people make a decision. The context that they're in affects that choice, and using the science to frame your messages can make all the difference and transform the emotional impact of your messages, thereby changing behaviour. And I think all of that is summed up very nicely and succinctly by the quote that's on the screen now from Dan Bennett at Ogilvy. But for me, the real difference with public health campaigns is using behavioural science enables you to really focus on delivering real impact, changing people's behaviour, real outcomes that make a difference to people's health and well-being, and going beyond what we often measure with a lot of campaigns and a lot of projects that we do, which is very often we don't go beyond reach and impressions, and it's actually making that physical difference, people taking your actions, and that for me is the real difference. This can all sound daunting, but it doesn't need to be. I think it's something that I believe strongly that it is something that all public health communicators can do, and can do in-house, with a little bit of, expertise brought in, or support brought in. So I was now going to ask you to do a second poll, which isn't working. JP, could you put the question in chat maybe? Would that work, the second one? So I can't see.
I can ask it here. I think it'd probably be better. We wanted to find out, after we've heard from Nupur, about looking at some of the potential campaigns that you're working on at the moment. So if there's a campaign that you're running or planning, we would like to sort of do a live demo of how you could apply some of the theory that we're discussing in this session today. And so if you could put in the chat, I'm going to put in smoking cessation, because I have to be working on a few of those campaigns at the moment. But it could be anything like childhood immunisation, childhood obesity, using the right service at the right time, demand management, encouraging people to move more or to eat more healthily, any sort of health or public health challenge. Please stick those in the meeting chat, and I'll do a quick I'll do a quick synopsis, so that once we've heard from you, we can then focus on an example based on what you guys are working on at the moment.
Thanks, John Paul. So just before I bring Nupur in, I just wanted to focus on a little bit on research and insight. In my opinion, the research and insight phase really is the most important part of any public health campaign. It's the unseen part, particularly the unseen part of behavioural science, that is often undervalued. It's the place where many campaigns fail from not doing a robust research and insight phase. We've all been guilty of jumping to answers and jumping to solutions before we kind of fully understand the problem, or we fully understand the barriers to the behaviour that we're trying to change. And the research and insight phase really, it does help prevent that. Also, just as frustratingly, many public health campaigns do a good research and insight phase, and then they fail through choosing the wrong channels, or not being able to get the right data to be able to kind of prove what a difference they're making. And often, especially if people have put in a lot of effort to do a robust research and insight phase, which, was something new to them, and then they don't see the results they were hoping for, this can put people off behavioural science. So just very briefly, because I'm sure Nupur is going to expand on this a little bit, but for me, a good research and insight phase will help you understand the kind of underlying factors or root causes of behaviours. It will enable you to develop your interventions, which are grounded in evidence. It will measure the effectiveness, so it will give you a baseline, and it will give you ongoing measurement by understanding what influences behaviour. You can predict the outcomes better and adjust them to maximise impact with your audiences. Similarly, insight allows you to understand your population much better and customise what you do to meet their needs and the insights you've got from them. For me as well, it also provides the deeper understanding to really hopefully enable sustained change and not just a one-off change. So yeah, I'd like to bring in Nupur, who's going to introduce you to some of the theory and also give you some examples of when this has been applied. Just sharing.
Thanks, Russell. I'm just going to bring my slides up.
Yeah.
Russell, I can see you. Can you see those slides?
Yeah, I can see them. Yeah, thank you.
Great. Thank you very much. So as Russell said, I'm going to just take you through a little bit today around really thinking about what behaviours are. That sounds very simplistic, but the reason I say that is we're often focused on outcomes. It's really important for us to understand what's the behaviour we want to change. Russell's covered a lot of this actually, but really starting to move away from that more intuitive or status quo approach of what you've always done. Now, sometimes that works really well, so we don't necessarily want to upset it if it's working well. But I think, as illustrated in the numbers you were putting in really honestly there in the chat, there's probably margin to improve and do more. And for that, we then start to think, right, well, what's the evidence? What's the theory? What do we pin it on? And I'll take you through a model today called the COM-B model, which I'm sure many of you would have come across. And just something to bear in mind throughout all of this, behaviour is really complex. It is hard to change. We're all out there doing the good fight. We want to get things better for our patients, our service users, our clients. But it is hard. And therefore, if we try and simplify it and pin it on evidence and theory as much as possible, it can most definitely help us. So just a reminder, what we're all trying to do all the time is we're either trying to change or influence a behaviour. And again, really evident by the things you were putting on the chat there about some of the great work that you're all doing, whether that's trying to get people to think about switching or stopping smoking, improving their diet, getting more active, brushing teeth, engaging with our communities. Immunizations came up there as well. Really what we're trying to get to the root of is, how do I change this behavior, or how do I influence somebody to make a change? And therefore, it's really useful to go back to the rainbow model when we start to think about the wider determinants of health, and we're trying to frame how much behaviours influence. Now, I know on this call it's a public health audience, so I'm sure most of you have all come across this. It's a really helpful model by Dahlgren and Whitehead, which has been in play for over 30 years. And of course, at the middle, we've got our biological factors we're born with that we can't do a great deal about. That, of course, hugely impacts our health. And as we traverse those layers, we see different things coming into play, like the lifestyle we lead, unemployment, access to water, to nutritious food, healthcare, our general cultural and socio-economic environment around us. And if I got you to look at that list at the bottom to say, well, what impact as a percentage does environment have on your outcomes with health or healthcare or these other things? And I'll pull those percentages up for you. So, for example, your genetics play 30% in that, your environment about 5%. If I was to say to you, well, what do your behaviours play with that? It'll be really interesting to hear from you. Maybe you can drop it into the chat, which I can't see. So Russell and JP, maybe you could help me out and let me know what sort of numbers people are dropping in.
Yeah, we've got 20% so far.
Okay.
40%.
Okay.
60%. Quite a range.
Yeah.
35%, 50, 40, 40, 35.
Okay, great. Thank you. So the flavour is that it's higher than what I put up, and actually you're spot on. It's 40%. And something here that always strikes me is, of course, we need to get healthcare right. We've got a new government now, so we'll see what they come up with. But it really strikes me when I look at these stats and say, wow, 10% impact is healthcare, but 40% is behaviours, which is why it always comes back to public health and what we're doing, not just for people that we know have got diagnoses, but what are we doing in the preventative space? So what's a behaviour? Not in any way meaning to patronise anyone, but I when I start out with things, often can sit there for a while and think, hang on, I've been going on about an outcome. That's what I want to achieve overall. And it's really important, because the number of projects sometimes that I see where they're all very well intended, but actually the focus when they're deciding what to do is they're still looking at an outcome. Now, I put a few things on the screen there just to sort of illustrate the point that, if you took a quick look at these all seem like very well intended things to work on. But for example, injury at work is an outcome. So if we're talking about how do we decrease injury at work, you want to start to look at the range of behaviours that people are engaging in that cause an injury at work. So I would always say, always come back when you've started, we always start with outcomes, because there's a decision made about what needs to change. But remember, that needs to then be broken down into a list of target behaviours, because that's where you're actually going to create the activity that moves that outcome. So just a little bit of a reminder about always break it down to a range of target behaviours and then make choices. So when we're thinking about the applicability, you know, within public health, population health, we've got our different layers of prevention, which sort of came out in that rainbow model that I showed you as well. But essentially, you know, and I can't probably hammer this point enough, we really need those evidence-based interventions, whether we're talking about one-to-one interactions in a consulting room to wider public health campaigns. And we have to absolutely start moving away from this islagiat, which is, it sounded like a good idea at the time. And I'm sure lots of you, and you know, this is something that when I came across it, it did actually make me giggle. It was in my master's, and all the tutors would say all the time, it's amazing how much of this you'll see. And suddenly I started noticing it everywhere, that we're trudging along sometimes doing what was always done, because intuitively it just seemed like a good idea, you know, like an expensive poster campaign on the back of a bus telling us to eat more fruit. Well, actually, what was the evidence base? What was it telling you about the previous campaigns before it was decided that it was worth the money or the resource? And did it actually create the behaviour change you wanted to create? So just a little bit of a reminder there about how we need to start moving more towards that evidence base. So that's all very well, but what do we do about it? So I'm going to talk to you a little bit about this model called COM-B. And again, I'm sure lots of you use this, have come across it. The reason why we see this crop up a lot in public health, in healthcare, in social care, is it's actually the behavioural model with the most evidence. There's lots of research that's been done within health, whether we're looking at things around prescribing, around infection control, around vaccinations, and essentially why this works so well is these three, what we call determinants of behaviour: capability, opportunity, motivation, that actually cover a huge breadth of determinants of behaviour. And as you can see, they interplay with each other to determine a behaviour. Now, when I say that, what I mean is capability, if we say psychological capability is how much knowledge or understanding you have about something, if you know that something perhaps is really good for you, that might increase your motivation to do it. You see lots of positive outcomes, that increases your motivation more, so it impacts. So these are really useful to understand as a system. And these can be broken down with two sections in each. So with capability, I talked about psychological capability, which is having the knowledge to understand why you would engage in a behaviour. Physical capability is actually having the skill set. So for example, I want to go off and start playing tennis. Do I actually know how to do it? As a, you know, off the top of my head example. Motivation. Now we can break this down into automatic and reflective. Automatic motivation are emotional responses and habits. You're not thinking about it too much, you're just doing it. Whereas reflective motivation goes a bit further as a cognitive process from just psychological capability, because what you're doing is, with that knowledge, you're juggling that information, the pros and cons, what those different outcomes mean, and then you're making a decision based on that. An opportunity we describe as anything external to a person that determines behaviour, and we break it down into physical and social. So physical opportunity could be resources and time. So for example, if we're trying to think about encouraging physical activity, do you actually have a space near you that is available, easy to access and safe for you to walk in, as an example? Social opportunities, again, are things that dictate our behaviours, such as social norms. So the influential people and messages around you that you are actually going to listen to, what are they saying? What's the cultural norm within which you're in that's going to influence your behaviour? Now, to give you an example, I had to do an assignment during my master's. So it was hypothetical. And because my background is primary care, I pulled apart this behaviour and used COM-B for it. But it's just an example. You can extrapolate this to anything you're doing. So what I wanted to work on as an outcome is, we've got a lot of people over 65. Generally, it's a national problem, but certainly in southeast London, who turn up to hospital because they're having adverse drug reactions and side effects to drugs like ibuprofen. The reason it happens more commonly in older people is because they're more susceptible. So I wanted to pull this apart and say, right, well, that's the outcome. What are the behaviours? And I looked at a few different things, and essentially the behaviour that I decided on is getting the prescribers in primary care, because about 80% of prescriptions are handed out in primary care as opposed to secondary, getting those prescribers, so predominantly GPs, to prescribe paracetamol first line instead of NSAIDs, which are ibuprofen and its family drugs. Now, as a target behaviour, I had a list. So we had things like, do we, for example, restrict over-the-counter sale of ibuprofen? Now, that goes much deeper into legislation, but decided actually that's quite draconian. It would probably not do much for a pharmacist client relationship. Plus, we couldn't really find a way to appropriately measure that, as an example. So that wouldn't be as good. And also, sorry, can you still hear and see me? Because
Yes, we can.
All
Yes,
good.
we can.
You can. Great. Thank you. Thank you for shouting that out. I just lost you for a second. So, you know, so the point that I was making is you'll find lots of target behaviours that will come up, and you will decide which to work on depending on how cost effective it is. Is it really going to achieve the impact you want? Can you measure the change? So the reason I went for this is we can easily measure it by prescribing data. We're likely to affect behaviour change, and we're going to create a big impact with decreasing adverse reactions in this population, as opposed to doing something more like restricting over-the-counter sales, or by saying to GPs, just absolutely refuse that prescription, because ibuprofen does have a place in therapy and it can be effective for certain things. So, and I apologise for the way this looks. I've tried to enlarge it as much as possible. So when I ran this through the COMBI model, in terms of, I looked at all of the different things, the capability, the opportunity, the motivation. So in terms of physical capability, we said, right, well, for GPs to prescribe, they need a way to do it, a handwritten prescription or electronic. Is there a need for change? No, they already do this. In terms of psychological capability, GPs need to understand the outcomes of the risks and the adverse drug reactions. So is there a need for change? Yes, although very conscious, we've got lots of education, delivery and guidance already available for this, and we're not quite seeing the change we want. In terms of physical opportunity, GPs do need the time to discuss with their patients why they recommend paracetamol over ibuprofen. Is there a need for change? Yes, absolutely. In terms of social opportunity, could we actually start sending messages to GPs telling them how well colleagues are doing in reducing their prescribing of ibuprofen for this group? And we know that modelling and social norms are a really powerful changer of behaviour. So we said, well, yeah, there could be place for change here. And then we move to the last part, which is motivation, which is GPs need to actually develop the intention once they weigh it up to want to prescribe their over 65 patients less of this and more paracetamol. And automatic motivation, so they just do it habitually. They just automatically prescribe paracetamol 65 for pain. Is there a need for change? Absolutely not, because we need to be really careful here. We still need there to be a reflective process. Indications, someone could be allergic to liver condition, which means they can't take it. So we absolutely don't want to get into the stage where we make it automatic. So when we ran it through this model, we said, well, the behavioural diagnosis here is we could look at psychological capability, social and physical opportunity, and reflective motivation. And then what do we do with that? So we know what we can work on. So here is where we can use something called the behaviour change wheel. Now, this is a really useful bit of kit, and essentially it's got the COMBI model at its core. You can see there it's all in green. And what this has done is it's a combination of 19 evidence-based behaviour change frameworks all pulled into this one behaviour change wheel. And essentially what it's done is it tells you the outer circle, which is in red, what possible interventions you could go for, and the grey part tells you the different policy categories you could look at. So again, I'm taking you on this journey of how I ran this through this model. So I then used the behaviour change wheel. And essentially what I settled on once I ran it through was, well, we could definitely look at improving education of GPs about the adverse outcomes. But maybe instead of the standard just talk to you in an educational setting, let's think about how we deliver this intervention differently. And this is the great thing about the behaviour change wheel, is it introduces things to you that perhaps you hadn't necessarily thought of. So something came up around a BCT is a behaviour change technique on giving feedback on outcomes of behaviour. So we could say, this is your individual prescribing data for your surgery. This is the number of your patients age over 65 who've had an adverse drug reaction because of ibuprofen. This amount then ended up in hospital with a bleed or an ulcer or a hemorrhagic, a bleeding type stroke. And that's very, very powerful as a motivator. We can also start to use prompts and cues. So we've got software that we use in GP surgeries already that's already paid for, so very cost effective, and we can design the messages. So for example, with the social opportunity, a message can come up when you're prescribing ibuprofen and it triggers something because the patient's over 65 and it says, your local GP colleagues have reduced their prescribing in this cohort of patient by 20% in the last 3 months. We suggest you prescribe paracetamol if safe. So that's the kind of nature of messaging you can use, and that falls into environmental restructuring. And that also picks up on the social opportunity there. So we're kind of covering that all with that messaging, the environmental restructuring and also the modelling. And we've got a really good way to measure it. So we can see the impact because we look at the prescribing data. So as kind of an example, as I said, of how something that starts as an outcome, which is we really need to get these, our over 65s who are turning up having lots of unnecessary bleeding from their stomach and ulcers, really dangerous situation. How do we improve the outcome? Well, what are the target behaviours? Let's run it through COM-B, then let's run it through the behaviour change wheel. So this is an example of how you could do that, and you can extrapolate that to whatever public health campaigns or projects you're doing. So if I was going to bring that all together, sorry, I don't know why this, there we go. So you start with research and insights, which Russell described already. Part of this would be your deep dive in the literature. So what's it already telling you about this type of outcome you want to work on? What's the local research and your community engagement? But also, that's all qualitative, really important. Also, what's your quantitative side? What's your data telling you? And you combine that all together, these insights and research. You then say, right, what's the outcome? What are the set of target behaviours? Now I've got my list, which is the most cost effective, which has got the most impact, what's going to create change, and you go for that. You then analyse that using a behavioural model like COM-B, which will give you a set of things that you can work on. And then you can start your mapping onto the behaviour change wheel and then go for the most appropriate intervention functional behaviour change technique. It's also really helpful, I have put that at the bottom, which I've alluded to really when you come, for example, to deciding the target behaviour. There's a model, for example, called APPEASE. Is it affordable? Is it practical? Is it effective or cost effective? How acceptable is it? Any side effects, and is it equitable? Because we always need to think about, we might be improving things for one part of the population, but we don't want to be creating inequity with our other parts of our population. I'm very much just throwing this in as an additional behavioural science part now that I've taken you through the COM-B, just as an example of where else we can use this in wider campaigns. So this was a letter that was sent to particular GP practices back in 2016, where they very much harness behavioural science. And I know it's really small, I'm not expecting you to be able to see that, but essentially this came from the Chief Medical Officer at the time, which was Dame Sally Davies, and it was to try to get those particular practices prescribing huge amounts of antibiotics, where we know there can become issues with resistance, to decrease. So essentially they used a few techniques here. So first of all, there's a line in bold that says the great majority, which is 80% of practices in England, prescribe fewer antibiotics per head than yours. So what we're trying to do there is create social norms, which again goes back to the COM-B model around, we all want to fit in, essentially. There's a real human drive for this. So they've harnessed using social norms there. There's an influential messenger who signed off the letter, which is Professor Sally Davies. And we know that this works quite well when we're trying to influence behaviour. The important thing here is who is the influencer. And there's something known as the intention behaviour gap. We can all be very well intended, but we don't do things. And I think we all know this. How many times have you said you won't eat that extra donut, or you're going to go for a run and it doesn't quite happen? So we know there are things in the middle about how we bridge that gap. And in this letter, they've given 3 really clear ways about how that GP can bridge that gap, which is, here's a signpost to a leaflet that you can give the patient. Consider doing something called a delayed prescription. So they still leave with a prescription, but advise them to not use it for another 3 or 4 days unless they're still unwell. And also talk to the other prescribers in your practice to change your behaviour together. So when we translate things like this into real life in primary care, with social norms, for example, when batch messages are sent out, we often encourage practices to use framing such as the majority of patients attended their diabetes review this year, if you're sending a reminder about that, rather than just you are due your diabetes review. Influential messenger. You have to be really careful with this. We saw this in COVID in Greenwich, where we had GPs well-intended sending videos out to patients to get vaccines, and it didn't work. And actually, when we went to using their local ministers and religious leaders, it worked a lot better. So you need to be clear about who the messenger is. But an example could be if you've got a well-established pharmacist, for example, in the practice who does all the high blood pressure reviews, that this person is directly reminding you to book in for your review. And intention behavior gaps, you know, the message could also be framed with, actually, we suggest you add this appointment to your phone or calendar now because it will pop up as a reminder. They're less likely to miss it. Or we offer weekend and evening appointments. Again, you're bridging an intention behavior gap to someone turning up. And it's always context dependent. Just to go back to that GP antibiotic prescribing letter, you know, over 70,000 doses of antibiotics less were prescribed across nearly 800 practices in the year the letter went out, savings of £92,000. And it just shows you a letter just framed, putting something through COM-B using a behavioural science approach can have such an impact, which is relatively really cheap to do and to send out. So it doesn't always have to be the most expensive or the most complex thing to do. So just a few take homes. Effective interventions have to be based on sound theory. The Medical Research Council tells us this. We just need to go forward with it. We are trying to change behaviours or influence most of the time. They're complex, they're not one-dimensional, but you break it down into a list of targets and pick the most effective one. Really define that behaviour and then think about using an evidence-based model such as COM-B. The great thing with COM-B is it then takes you to the behaviour change wheel that can support intervention design. And probably just the last thing I'll say before I finish, and sorry because I know I'm running a couple of minutes over, is it feels a bit overwhelming. I'm very conscious of that when I've just taken you through that. But once you use it once or twice, actually you can see the real benefit, and you don't need a sort of big complex organization to come in and do this for you. There's a really stepwise way of doing it, and I was sort of surprised with actually when we're just following the steps that it can be relatively straightforward, because what you're doing at the beginning is you're making it as simple as possible because it forces you to do that. So that's my other slight tip. Don't get overwhelmed by it. It's very possible to do. And I'm going to stop there.
That's great. Thank you, Nupur. So we asked you earlier to put in topics that you were keen for us to look at the approach. I've done a sort of a bit of a tally. I think to me it looks like it's joint vaccination stuff and smoking cessation. Now the vax stuff is split between general vaccinations and childhood vaccinations. So I think smoking cessation is probably ahead. So let's cover that one if we're okay. What I would say is a lot of the topics that you put on there, we have done webinars previously, so do have a look at the Public Health Comms Hub, but particularly the one around Use the Right Service. We've done quite a lot of stuff on that. There is a blog on winter planning that I'm working on at the moment that we're going to be sending out to all of you soon, so keep an eye out for that. But also have a look, there's a really good case study from Edna Wampong in Telford, Wrekin and Shropshire, where they really did evidence over £5 million worth of savings to the health and care system in that area. So there is stuff out there on things, so don't be disappointed if yours isn't going to be covered today. But I wonder if we could just spend a little bit of time. And we're not going to, we're slightly contradicting ourselves because we're not doing a robust research and insight phase. But we're not going to have all the answers without doing that. But maybe we could just talk through kind of the processes we might go through if we were planning a smoking cessation campaign. Nupur, would you be okay to go first, or give your thoughts, and then maybe me and JP will add ours?
Yeah, happy to. Thanks, Russell. So, as you said, if we had access to some qualitative what's happened locally, both on the ground, in our borough and wider, where we are, would be really useful to know what's already happened. Pulling some data in is always helpful to get the quantitative part, and also a bit of a literature review. So that would be your first step, and then based on that, and I think this is where the community engagement as part of your insights is so important, because it's also something about what do people want, what are they missing so far in a topic like smoking cessation, because obviously we've been trying to make efforts there, I mean, for years and years and years. So there's obviously something about coming out of our own assumptions. What is it that the people we're providing the service for need and want? So if we sort of make a massive presumption that we've done all that, and then we sort of move to, right, well, what's the outcome? So is your outcome that we want to, we want to reduce smoking rates in our borough by X amount? So outcome, and then we can start to get the behaviours, and there's lots of behaviours here. So if we're looking at the people that we would like to change behaviour, are we saying we would like more people to uptake nicotine replacement therapy? We would like more adults who have found it difficult with nicotine replacement therapy to consider vapes. We would like there to be more opportunistic signalling when people turn up in community spaces or at the general practice or secondary care, directing them towards smoking cessation. We would like our community pharmacies to be having raising more awareness when people pick up prescriptions of smoking cessation. Do you see what I mean already? And I could go on and on and on here. So what are the target behaviours? Then look at them and run it through something like a PEAS. What's affordable, what's practical, what's cost effective, what's got impact, what can you measure? Because this is the other thing, how are you capturing it? And you must know what your baseline is, so you know if you made a change. So I would say that bit is the real important bit. And then of course, once you've got a target behaviour, I would say the temptation here is to run away with all of it. And I think you need to say, what's my timescale? And within that, therefore, what's affordable, practical, cost effective, measurable? And once you know that, then you start to run it through COM-B and say, right, where are those pressure points with capability, opportunity, motivation? And then when I look at that, again, you're kind of always got that appease criteria in your mind when you're coming out with these intervention functions and behaviour change. What can I actually do that, again, is cost effective, will really create behaviour change? So I think you kind of run it through in that systematic way. And I think probably something that we're not as good at is always thinking about sustainability. Now, I know a lot of this is because we don't have as much control. I'm sure lots of you have been in these situations as I have, where you're sort of told with 8 weeks before the end of the financial year, someone's found a funny pot of money and could you do X? And we never want to say no to that. But what I would say is, when you're doing that bit of planning, building the sustainability. So yes, this is a pilot. I've ran it through the COM-B and behaviour change wheel. This is what I can do. But realistically, I need this amount of time to show impact. But what's the sustainability part, so it can keep going once you've done your behavioural diagnosis and you've implemented it? So that's my bit of brain dump, I think, there, Russell, if that's helpful, JP.
No, that's really good. I mean, I think in terms of then taking that and translating that to a campaign or a communications campaign, I think for me the COM-B is really helpful for that, and I've used that a lot in terms of developing, using what we learned from the COM-B, particularly around the barriers, what's stopping people to do the target behaviour that you're looking for, and also what might enable people to have that behavior, or to take that behavior. And what you do then is you take that and you develop your messaging based on what you hear, what you get out of the research and insight phase. And it may be that there's something as well around, we talked about there are several behaviors around smoking, and which, if we're targeting more than one behavior, there may also be several kind of target groups, and with smokers, we know that there are, very, very entrenched smokers who smoke heavily and smoke every day. There are, more of your, I guess lots of people class as social smokers who smoke less days per week and less in total. And we know from looking at previous campaigns and insight that's out there that different messaging is needed for those different audiences. So, but I think the key thing for me as well around the behavior change and behavioral science approach is developing those messages, but then testing them with different parts of your audience and seeing what works. Because just because you think it will achieve the behavior you want doesn't necessarily mean that will happen. And there are quite often unintended consequences of interventions, and they can be positive ones and they can be negative ones, but without testing them, you don't come across those. So yeah, that's my take. And then I think a really key thing is thinking about where your messaging goes, and I'd like to bring John Paul in to talk about that.
Thank you. Yes, and also thank you, Nupur. You apologised at the beginning for, like, you were sort of teaching people to suck eggs, but I took so many things. You went in more depth than I've seen before, and appease and things like that. I think are so applicable, particularly when you're dealing with populations maybe who have from low income backgrounds. So that's been really useful. Thank you. I think some things to look at. In terms of what is on the minds of your target audience, search data is incredibly useful. What you can do is take a specific area, the area you look after, and then get search history on the specific terms being put into Google and into Bing, and to see where the volumes really are. In terms of what people are being motivated, what concerns are on their mind. Here we can see, for example, very high, consistent searching for nicotine patches in West Yorkshire, and also maybe some of the health concerns that might be driving motivation to make a change around health. So anyone who's in the health hub, we're happy to give these for smoking cessation, but also vaccination, MMR, and so on. It's wonderful data which helps you understand what's on the minds of your audience, so it can help influence your approach. I think it's also very important to think about the landing pages, the user experience at the other end. You're going to find people, you're going to put a message in front of them that's been beautifully inspired by the behavioural insight you've done with Russell and Nupur, but now we need to take them somewhere that's going to make it really simple for them to take the next step. So having something that's just really quick and works well on mobile is really important. I'm probably breaking all sorts of GDPR for myself here, but I give consent for that to happen. But to create a stream of quit attempts or people referrals to the service, I think is absolutely key. And then using maybe some of that search insight to then target those specific phrases and place search ads, so that when someone's typing nicotine patch or impact of smoking on my health, they're then taken directly from there through to that sort of quit attempt user experience. So there's that sort of navigating people who are already in market, but there are also approaches where you're using yes, search, but also social media, YouTube and other platforms to target people, maybe not the individual smokers themselves, but maybe people around them, to nudge them, how to have a conversation with someone who's given up giving up, how to ask someone about maybe now's the time. Things have changed. Often the people we're dealing with have tried multiple times before, so equipping the audience around them is very important, and thinking about all those different channels as we go. I think those are the sort of the top tactics. I loved as well the stuff that we're talking about around socially norming. You know, saying, for example, that 92% of people in the area don't currently smoke, or that 60% of smokers like you have succeeded in giving up cigarettes by switching to vapes. I think those sorts of things can be really powerful, so that people feel less isolated. I think when you're dealing with addiction, it's about tapping into support and those senses of connection that can be really powerful as well. So there's lots of digital technology which you can apply to make sure that the messages get through frequently to the right people in the right places, in the right contexts. And I often say that, programmatic advertising, it's like it's been designed for applying behavior change theory, because you can get those trigger points. You can reinforce, nudge, try lots of different messages out on audiences, and really start to drive down that cost per quit attempt. So those would be the various things that I've seen that we could apply here for you.
Yeah, no, I agree. And just building on a couple of those points, I agree around social norms being really useful. And, it could be, we know that lots of entrenched smokers have tried quitting before and gone completely cold turkey with no support or help, and that nearly always fails. So a good social norm could be, 60% of people who've smoked for more than 10 years gave up with support, or something like that, and to try and sort of nudge in that direction. I think on the influential messenger bit as well, family members, I think, could be really key. We've focused in a previous webinar, a film that they've used in Greater Manchester with a daughter at her wedding day. The father can't be there. The father's written a note for the wedding because he's in hospital and can barely breathe because of his smoking. I think there's using those influential messengers in your campaign materials, but also targeting them, as John Paul alluded to as well, to try and directly influence their family members is a really good tactic. And just going back to the intention behavior gap, I think if you can make it really easy for people to set a quit date, or take a positive action that in their head kind of is a commitment to it, and a commitment to taking some help, or submitting your email address or whatever it is, but just some sort of tangible step that kind of cements their commitment to trying to give up. Yeah.
I saw an interesting comment about the number of non-daily smokers increasing. Yeah, we've heard this from other locations as well, and that people don't really perceive themselves as smokers if they just have the odd one. That's very pertinent to a number of campaigns that are running at the moment. And there are tactics you can use, like, for example, targeting the areas where people are out, where the nighttime economy is, and targeting users there, and then retargeting them the day after. So when you've got the raspy throat and the hangover, targeting the intervention at that time can be really powerful. We saw that work in Stop Smoking London, and almost quadruple the interaction rate. So that there are wonderful techniques that you can apply even when you have something like that could appear to be quite hard to surmount.
Great. I can't see any other question. I can see a question actually just popped in from Louise. Question about words used in behaviour change comms messaging. Pick this up doing active travel comms. Never say cyclists or pedestrians, as that can create an image of a tribe. Better to say people who prefer to cycle or people who prefer to walk. Are there any resources to find out more about choice of words? It's a really good question. I'm sure there are, but I can't think of one off the top of my head. So we might need to come back to you on that, unless Nupur or JP, you're aware of anything.
I think there's a lot around the language used around care that's applicable to this. So being careful about triggering negative processing in the mind around certain things. Yes, there's quite a lot. We will I'll do a bit more research and send some of the potential prompts for that. But the things like avoiding hidden instructions and understanding how the brain processes information can be really useful to filter out messaging which could have the opposite of the intended consequence.
Yeah.
Nikki's asked about the budget of the current climate of zero budget.
Yeah.
There's a few tips there. Firstly, your owned channels. If you're in a council, you've got a real superpower because you're able to use email newsletters, advertising on the website, even your out-of-home contract sometimes has some free space in it that you can use to generate awareness. I would challenge if someone says we want you to do something but there's no resources or no budget at all. It's often interesting to just ask them, well, if we do nothing, what happens? And get them to work through that in their minds, because if they're fine with that, let's just do that and save each other time and focus on another intervention that maybe does. Often you can get to the bottom of it and realize that there is a cost and therefore an invest to save business case can be made. I think when you're dealing with addiction and also reducing future late intervention costs, there really should be a budget there, and if there isn't, it's well worth challenging that. So a gentle way is to say, if we do nothing, what happens? And sometimes you can take them around the houses on that.
Just to add to that, I think I mentioned at the start around trying to stop doing some of the stuff that we know doesn't have impact. I get asked over the years, I've been asked to do loads of stuff that we know just does. It's tick box communications that we do, and actually, okay, we may not be spending money on that. But what about all your time you're putting into it, or your colleagues' time that's going into it? There's a monetary value to some of the stuff that we know isn't having impact. We lots of us in comms now spend lots and lots of time doing organic posts, which don't work like they used to. They don't reach people like they used to. Where the majority of the time we're wasting our time with that. That time could be used doing something much more productive. And actually, what I would say is get some of those case studies. I mentioned Edna in Telford, Shropshire and Wrecking. For a £90,000 investment, she was able to demonstrate with good use of data over £5 million of saving to the system. So I know it's difficult to get hold of money, and it's at the moment, but if you can use evidence as strong as that, then it should hopefully make it easier to access even just a small amount of money. And I think our point is that you can do quite a lot without a huge budget.
Yeah, and I just add to that as well. I think that letter that went to practices across England is another really good example of that. That was a selection of letters harnessing three main powerful uses of behavioural science and behaviour change techniques, which was, give social norms. 80% of practices are prescribing less than you. That's it's quite a bit of a hit in the face, really, when you open that letter. And there was something around the influential messenger. It's really easy about who signs off that letter, and intention behaviour gaps. Give people 2 or 3 really easy steps. And those, we're churning out comms, we're churning out lots of these things anyway. Has it been thought through framed on a behavioural model? So I think there are, and as you said, John Paul, there are things that are already in existence from the perspective of your own channels. The example I pulled out there, we've already paid a lot of money for prescribing software as an example, and I think that's in some ways the beauty of the COM-B or the behaviour change wheel, that there's lots on there. You will throw a lot of it out because a lot of it will be far too expensive, far too time consuming. It's not going to be practical. But what it does is it opens you up to consider everything that's in the sphere, mostly everything, because research is always ongoing. And that's what it does. Like, have you thought a bit laterally, and have you applied something like appease to it, which will suddenly really start to cut out things that are not going to be affordable, practical, you just can't do them, and those things that you actually can do.
Brilliant. There was a question from Bola about triggers, really. If you do smoking cessation, but the people live in a household full of people who are smoking, or you want them to eat more healthy, but they're surrounded by chicken shops, or you want them to stop gambling, but they live in a place that's riddled with gambling shops. How do we work around that? Well, unfortunately, I don't think you can work around that. You can't realistically request someone moves house into a sort of rural environment, a real healthy environment from that. But I think you could use messaging that educates people about triggers. So being aware of triggers is it is part of it, but it's a huge challenge, a huge uphill battle. And it's not just physical that's the problem. Advertising companies, particularly audience technology companies, have built audiences of gamblers, and these are sold so for someone to escape the trigger for online gambling is actually incredibly tricky without being forgotten and starting again with a new device. So yeah, I mean, whether that's done at the top line campaign level, but helping people understand the nature of addiction, triggering, and so on, using video, for example, could be a tactic, but it's not an easy challenge to overcome.
And just so somebody's mentioned in there about the behaviour change wheel and giving examples. There is a great book. It sits on my shelf all the time. It takes you through the process. It's quite a good thing to have. Maybe convince your department to get it as a resource. But I think if you generally got onto Google Scholar and you put in something like Combi behaviour change wheel for smoking cessation, you'll get a lot of things that will come up. So you don't need to necessarily purchase the book. So you will get lots of examples there as well. That would be helpful. And I can see it. Very happy to share my slides, John Paul. I've got a slightly updated version which I can send you if that's
Good. Have we covered all the questions?
I believe so, yes.
Yeah, okay. I'm just going to conclude very, very quickly because I'm aware we've gone over time, but I've got a couple of slides just about helping, or one slide just about helping you get the buy-in to the approach, and some tips really, which I would just quickly share. Sorry. Trying to do too many things at once.
Don't worry.
There we go. So just a few tips on trying to get buy-in locally, which can be a challenge. People ask you to work on something, they want you to get on with it, and they want to see something out next week, or something out in a few days, or that day even. And I think that's a challenge. We're used to working in ways where we want to see the results quickly, but I think embrace that difference. Embrace the science. It'll take a bit of time. Mentioned earlier when answering some of the questions, present the clear benefits. Talk about why this is going to be better than a lot of the stuff that we currently do, which doesn't have any impact. Use the evidence. Use the case study. Show where everybody's got a competitive streak, and if you can show another area that's doing so much better than your area because they've done this, then you'll get that buy-in. Align it where you can with your organizational goals. That sounds obvious, but it will really, really help. And start small. Look for quick wins. Look for things that might not cost a fortune. That letter that Nupur talked about that was already going out, the cost to changing it was just people's time, the letter, start small, build your case, test things, and don't, get people involved, show that return on investment, and be patient and be persistent. If it doesn't quite achieve what you wanted to the first time you try it, that doesn't mean the whole process is bad, or it doesn't mean that you have to revert back to what you've done for the last 10 years or whatever. It means something, learn from it and adapt, and you might get it complete, you might smash it next time. So yeah, I think we should stop now anyway. Just wanted to say a massive thank you to Nupur for your brilliant presentation. It was really, really good. And thank you to John Paul as well for support and for your input today. And thank you very much to everybody for turning up. It was great to see so many of you. We'll share the materials with you all. And as I mentioned, there's a blog coming out soon around winter pressures, and we'll be advertising another of these webinars in the not too distant future. Thank you.